Granulomatosis with polyangiitis, formerly known as Wegener's granulomatosis, is a systemic disorder that involves both granulomatosis and polyangiitis. It is a form of vasculitis that affects small and medium-sized vessels in many organs. Damage to the lungs and kidneys can be fatal. It requires long-term immunosuppression. When referred to as Wegener's granulomatosis, it is named after Friedrich Wegener, who described the disease in 1936. Because of Wegener's association with the German Nazi Party, professional bodies and journals have replaced his name with a descriptive name. Granulomatosis with polyangiitis is part of a larger group of vasculitic syndromes called systemic vasculitides or necrotizing vasculopathies, all of which feature an autoimmune attack by an abnormal type of circulating antibody termed ANCAs against small and medium-sized blood vessels. Apart from GPA, this category includes Churg Strauss syndrome and microscopic polyangiitis. Although GPA affects small and medium-sized vessels, it is formally classified as one of the small vessel vasculitides in the Chapel Hill system. Signs and symptoms. Initial signs are extremely variable, and diagnosis can be severely delayed due to the non-specific nature of the symptoms. In general, rhinitis is the first sign in most people. Kidney, rapidly progressive glomerulonephritis, leading to chronic kidney failure, upper airway, eye and ear disease, nose, pain, stuffiness, nosebleeds, rhinitis, crusting, saddle nose deformity due to a perforated septum, ears, conductive hearing loss due to auditory tube dysfunction, sensorineural hearing loss, oral cavity, strawberry gingivitis, underlying bone destruction with loosening of teeth, non-specific ulcerations throughout oral mucosa, eyes, pseudotumors, scleritis, conjunctivitis, uveitis, episcleritis, trachea, subglottal stenosis, lungs, pulmonary nodules, infiltrates, cavitary lesions, pulmonary hemorrhage causing hemoptysis, and rarely bronchial stenosis. Arthritis, pain or swelling, often initially diagnosed as rheumatoid arthritis, skin, nodules on the elbow, purpura, various others, nervous system, occasionally sensory neuropathy and rarely mononeuritis multiplex, heart, gastrointestinal tract, brain, other organs, rarely affected. Causes. Its causes are unknown, although microbes, such as bacteria and viruses, as well as genetics have been implicated in its pathogenesis. Pathophysiology. Inflammation with granuloma formation against a non-specific inflammatory background is the classical tissue abnormality in all organs affected by GPA. It is now widely presumed that the antineutrophil cytoplasmic antibodies are responsible for the inflammation in GPA. The typical ANCAs in GPA are those that react with proteinase 3, an enzyme prevalent in neutrophil granulocytes. In vitro studies have found that ANCAs can activate neutrophils, increase their adherence to endothelium, and induce their degranulation that can damage endothelial cells. In theory, this phenomenon could cause extensive damage to the vessel wall, in particular of arterioles. Diagnosis. Granulomatosis with polyangiitis is usually suspected only when a person has had unexplained symptoms for a long period of time. Determination of antineutrophil cytoplasmic antibodies can aid in the diagnosis, but positivity is not conclusive and negative ANCAs are not sufficient to reject the diagnosis. Cytoplasmic staining ANCAs that react with the enzyme proteinase 3 and neutrophils are associated with GPA. If the person has renal failure or cutaneous vasculitis, a biopsy is obtained from the kidneys. On rare occasions, thoracoscopic lung biopsy is required. On histopathological examination, a biopsy will show leukocytoclastic vasculitis with necrotic changes and granulomatous inflammation on microscopy. These granulomas are the main reason for the appellation of Wegener's granulomatosis, although it is not an essential feature. Nevertheless, necrotizing granulomas are a hallmark of this disease. However, many biopsies can be non-specific and 50% provide too little information for the diagnosis of GPA. Criteria. In 1990, the American College of Rheumatology accepted classification criteria for GPA. These criteria were not intended for diagnosis, but for inclusion in randomized controlled trials. 2 or more positive criteria have a sensitivity of 88.2% and a specificity of 92.0% of describing GPA. Nasal or oral inflammation, painful or painless oral ulcers or purulent or bloody nasal discharge, lungs, abnormal chest X-ray with nodules, infiltrates or cavities, kidneys, urinary sediment with microhematuria or red cell casts, biopsy, granulomatous inflammation, within the arterial wall or in the perivascular area according to the Chapel Hill Consensus Conference on the Nomenclature of Systemic Vasculitis, establishing the diagnosis of GPA demands, a granulomatous inflammation involving the respiratory tract, and a vasculitis of small to medium-sized vessels. Several investigators have compared the ACO and Chapel Hill criteria. Treatment. The standard treatment for GPA is cyclophosphamide and high-dose corticosteroids for remission induction and less toxic immunosuppressants like azathioprine, leflunomide, methotrexate or mycophenolate move-til. Trimethoprim sulfame folxazole may also help prevent relapse. Rituximab may be substituted for cyclophosphamide in inducing remission. A systematic review of 84 trials examined the evidence for various treatments in GPA. Many trials include data on pooled groups of people with GPA and microscopic polyangiitis. In this review, cases are divided between localized disease, non-organ threatening, generalized organ-threatening disease and severe renal vasculitis and immediately life-threatening disease. In generalized non-organ threatening disease, remission can be induced with methotrexate and steroids, where the steroid dose is reduced after a remission has been achieved and methotrexate used as maintenance. In case of organ-threatening disease, pulsed intravenous cyclophosphamide with steroids is recommended. Once remission has been achieved, azathioprine and steroids can be used to maintain remission. In severe renal vasculitis, the same regimen is used but with the addition of plasma exchange. In pulmonary hemorrhage, high doses of cyclophosphamide with pulsed methylprednisolone may be used, or alternatively CYC, steroids, and plasma exchange. Prognosis. Today, with corticosteroids and cyclophosphamide, 5-year survival is over 80%. Long-term complications are common, mainly chronic renal failure, hearing loss and deafness. Before modern treatments, the 2-year mortality was over 90% and average survival 5 months. Death usually resulted from uremia or respiratory failure. Epidemiology, the incidence is 10 to 20 cases per million per year. It is exceedingly rare in Japan and African Americans. History. Scottish otolaryngologist Peter McBride first described the condition in 1897 in a BMJ article entitled Photographs of a Case of Rapid Destruction of the Nose and Face. Heinz Karl Ernst Klinger would add information on the anatomical pathology, but the full picture was presented by Friedrich Wegener, a German pathologist, in 2 reports in 1936 and 1939. An earlier name for the disease was pathergic granulomatosis. The disease is still sometimes confused with lethal midline granuloma and lymphomatoid granulomatosis, both malignant lymphomas. In 2006, Alexander Woiwat and Eric Mattson investigated Wegener's past, and discovered that he was, at least at some point of his career, a follower of the Nazi regime. In addition, their data indicate that Wegener was wanted by Polish authorities and that his files were forwarded to the United Nations War Crimes Commission. Furthermore, Wegener worked in close proximity to the genocide machinery in Angströmer Cube Dar. Their data raise serious concerns about Wegener's professional conduct. They suggest that the eponym be abandoned and propose ANCA-associated granulomatous vasculitis. The authors have since campaigned for other medical eponyms to be abandoned too. In 2011, the American College of Rheumatology, the American Society of Nephrology and the European League Against Rheumatism resolved to change the name to granulomatosis with polyangiitis. References. External links, classification criteria by the American College of Rheumatology, Largest Wegener's granulomatosis GPA patient support group.